Welcome to the Outbreak modules presented by the Thunder Bay District Health Unit IPAC Hub team. This two-part series is designed for our long-term care homes, retirement homes, and acute care facilities and provides an overview on how to identify, report, and manage enteric and respiratory outbreaks within their facilities. This presentation has been updated in November 2022 to represent ministry guidance changes that occurred in October 2022. This module is a recorded presentation. This is the first module of the two-part series. Feel free to pause the presentation at any time. If you have any questions, please do not hesitate to email us at ipachu@tbdhu.com. For congregate living settings that are not long-term care or retirement homes, we recommend you visit our congregate living setting respiratory management modules. Thank you and enjoy.
At the health unit and with our Ontario ministries, there tends to be a large use of acronyms. So we started to collect some of the acronyms here for your review, just in case any of these are new for you. So TBDHU stands for Thunder Bay District Health Unit. PHO is Public Health Ontario. OMT will be Outbreak Management Team. OB is for Outbreak. IPAC or IPAC is Infection Prevention and Control. HH stands for Hand Hygiene. ABHR is Alcohol-Based Hand Rub. PPE is Personal Protective Equipment. PP or PNP is Policies and Procedures. LTCH is Long-Term Care Home. And RH stands for Retirement Home. This module or session is an introduction to managing an outbreak within your facility. It isn't meant to train you on how to complete an outbreak, but rather to provide you information, resources, and guidance to work through an outbreak, whether it be enteric, respiratory, or COVID. Many of the facilities we support have already gone through at least one outbreak in the last year, but there are still some facilities who have never had one, while others have had their fair share. Factors that do influence outbreaks include the size of your facility, the age of your clients, and the health of those clients you serve. Every organization will experience an outbreak at some point. That is expected. However, each outbreak is going to be unique, especially to your facility. But with this education, discussions about experiences, and some guidance, we definitely can reduce the length and the negative outcomes brought on by outbreaks. So that is our main goal overall through this module. There is a lot of material to go through. Again, since this is a recording, go through the material at your pace. Take breaks when you need to by using the pause button. We have kept our break slides within this program just to kind of cue you when we've taken breaks previously in the live session, as well as when there might be a change in material. So you can see here that we have broken it down into like 4 main areas. So the outbreak process, IPAC outbreak control measures. So those are generic ones for all outbreaks. And then enteric outbreaks, and then respiratory outbreaks. So what we've actually done is split this module into 2. So the first module that we are on right now will cover outbreak process and the generic outbreak control measures. The second half, the part 2 series, is going to cover enteric and respiratory outbreaks. So you can feel free to split that into 2 days or a morning and an afternoon. But I definitely would at least allocate at least a half day to each module. So module 1 and a half day to module 2, just to ensure that you are able to absorb the information and process it, and definitely reach out to us. We still have the IPAC Hub email address if you have any questions about the data.
In the next few slides, we will briefly discuss an overview of outbreaks. Simply put, an outbreak is defined as an increase in the number of cases beyond what is normally expected based on surveillance data. Generally speaking, all outbreaks will fit into 2 categories: respiratory, and enteric. Respiratory infections include upper and lower respiratory tract infections, which can affect a person's sinuses all the way to their upper and lower lobes of their lungs. Symptoms can be runny nose, congestion, sore throat, cough, shortness of breath, and generalized malaise or fatigue. Enteric infections involve the stomach and gastrointestinal tract and generally cause abdominal pain, nausea, vomiting, and diarrhea, which can also lead to fever, chills, and loss of appetite. Respiratory tract infections are commonly diagnosed infections in long-term care and congregate care residents. Data from the Public Health Ontario Laboratory, PHOL, specifies the most common respiratory viruses causing these respiratory infection outbreaks are influenza A and B, enterorhinovirus, coronaviruses such as COVID-19, RSV, parainfluenza, and metapneumovirus. Enteric infections can be caused by bacteria, viruses, or parasites contracted through contaminated food or beverages or through contact with contaminated items or infected persons. Enteric outbreaks can be caused by any of these infectious agents and may also be referred to as gastrointestinal or gastroenteritis outbreaks. Now that we did a quick review on what an outbreak is, let's start by reviewing the outbreak process. Being prepared and responding to an outbreak requires the following steps: preparing ahead of time, identifying early, notifying public health, taking initial steps, preventing further spread, and debriefing for lessons learned. We are going to break down each step within this presentation. Step 1. Preparing ahead of time. Preparedness is key. It is something that no one wants to do and feels mundane, especially if you're lucky enough to not go into an outbreak, but it does make a big difference if you do experience an outbreak, and that is why it's worth the effort to ensure you are prepared. In order to prepare, the following should be considered. Policies and procedures need to be updated. Likely, all of our COVID policies and procedures are in place, as this is what we've all been focused on for nearly 2 years. However, you have to ensure we also look at the enteric and other respiratory outbreak policies and procedures, as COVID and new research and strategies have likely impacted these. You want to ensure medical directives are in place and all necessary consents are signed. For example, Tamiflu consents are completed for clients. The ability to administer Tamiflu if you go into an influenza outbreak reduces wait time to treat clients, which could assist in preventing another case associated with the outbreak. All necessary supplies are accessible and readily available in case of outbreak. This includes adequate supply of PPE, ensuring PPE is not expired, having alcohol-based hand rub on hand, lab specimen containers, cleaning supplies, laminated signage, etc. is available to put in place quickly. Next, ensuring staff involved with the outbreak not only know their role, but also feel comfortable and supported in their role, ensuring they know their policies and procedures and who they are responsible for. They've been given opportunities to attend education on outbreaks so they can do their best. Although a lot of navigating outbreaks is through learned experience, but having the knowledge and support going into it will only make the difference better for all. And lastly, all staff, as well as client, immunization records are kept current. With staff, this could affect who is allowed to work, where they can work, and if additional measures are required. The second step in the outbreak process is early detection. It is critical for frontline staff to know what to look for and who to report it to. They should be aware of who within the facility to bring this information to. Is it a floor supervisor, RN in charge, or group home supervisor? Ensure staff know who this person is and that this is part of their orientation, including ongoing education. Once this is brought to the designated staff's attention, A suspect line list should be started to monitor any affected residents or staff and keep track of any spread within the facility. We will go into line listing later in this presentation, but line lists are a visual aid to help identify outbreaks and epidemiological links with illness. The third step in the outbreak process is to notify the Thunder Bay District Health Unit as soon as an outbreak is suspected. TBDHU staff, most likely the public health nurse assigned to your facility, will review the line list and help prepare if the outbreak is confirmed. They will then determine and declare a confirmed outbreak as appropriate. This will be done by developing a case definition. A case definition lists the clinical criteria used to determine whether a person's illness is included as a case in an outbreak investigation. They will provide an outbreak number and specimen collection kits to your facility. They will send an outbreak notification to external stakeholders. This could include public health laboratory, healthcare providers, and/or ambulatory care notification. Provide guidance for outbreak management, and they will review your facility's influenza and COVID-19 immunization rates during respiratory outbreaks and provide guidance.
The initial steps declaring an outbreak. So once Thunder Bay District Health Unit has been notified, they will confirm and declare the outbreak. Typically, an outbreak management team, or the OMT, is created or already been created by this time. The outbreak may be declared between the facility representative and the health unit nurse, or declared during the initial outbreak management team meeting. The OMT will manage communication of the outbreak declaration. So an outbreak management team, this is a multidisciplinary, multi-organizational team who will oversee the outbreak, decide what control measures will be implemented during the outbreak, provide outbreak communication internally and externally, and navigate any unique situations that may arise during the outbreak, because this will occur. The first outbreak meeting should occur at the declaration of the outbreak or shortly thereafter, likely within 12 to 24 hours. So an example where this could occur is if the outbreak has been identified or needs to be declared during an evening shift, so after dinner or perhaps during the overnight shift, the information has become available. It would be too hard to find all the partners or reach them and hold that meeting during that time. So ideally, the very next morning would be the optimal time to hold it, but sometime during that next day, it would be really important to hold that meeting. And it's ideal to hold it as soon as possible, and that's to ensure that the important information is communicated and measures are put in place. Studies have actually proven that the quicker the response is, the less negative impact an outbreak will have, and the more likely you're able to contain the outbreak to one area or one facility. So at the initial meeting, a regular schedule for further meetings should be put in place. So this can depend on a few factors. It may depend on the organization or the facility's familiarity or experience with outbreaks as a whole, or that type of outbreak. So what agent is causing the outbreak as well. It is ideal to meet daily or every other day during the initial stage of an outbreak, as that's when you're still gathering a lot of information, and typically this is when the highest spread occurs. If the outbreak is not spreading quickly or it's starting to show a slow in its spread, that's when you reduce the frequency of the meetings. So with most of our facilities with typical outbreaks, we see 2 to 3 meetings within the first week. So it could be a Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And then as the outbreak progresses through, so likely slowing the spread, everything's pointing to hopefully it's going to be declared over, we see a decrease in the meeting. So perhaps just once or twice a week after that until it is declared over. The pandemic has changed this quite a bit. So at the start of the pandemic, due to the unfamiliarity of COVID, the changes with measures that we kept seeing, it was very common that we had daily outbreak meetings with our facilities and organizations. Um, so it was every day that they were in outbreak, there was a meeting. So you could just imagine we were having 10 outbreak meetings a day with different facilities. Now, within the last 6 months or later on within the pandemic, so this recording is in the spring of 2022, we tend to see that there'd be more meetings again in the beginning. So maybe daily for just the first few days, and then we reduced it to about 2 times per week. And that's again because COVID changed, we understood it a little bit better, and most of the organizations had already gone through 3 to 4 COVID outbreaks prior to this one. Again, there is no set schedule. It's what your facility and your team is comfortable with. So even if you say you're still going to hold it daily to start, then that's fine. If it's a short meeting, touch base, there's nothing wrong with that either. It doesn't say anything different. It's just ensuring that all that information is there for you. So the OMT meetings are with all partners. However, if the organization facility wants to internally meet in addition to these OMT meetings, then that's not an issue as well. Just ensure that the same information is provided at the OMT meetings and nothing left out or not brought forward. So here's an example of an initial outbreak meeting agenda. This first meeting will be the longest, so having a prepared template helps you keep organized, ensuring no information is missed. Your health unit nurse will have this agenda, or you can also access that through them, or you can also create your own. So let's look at some of the important information that you always want to keep on the agenda. So starting at the top, it should include the name of the facility and the location, as some organizations may have more than one location. Date, time, and location, which is now typically online, the meetings or on a teleconference. But if they are in person, it's good to include that location. It's also helpful information for anyone attending or looking back at this agenda to review. At the top, you'll see the outbreak number. This outbreak number is assigned by Thunder Bay District Health Unit to your specific outbreak, and each outbreak gets one. So even if you are an organization with 2 outbreaks ongoing, they each have their own unique number. So the outbreak number that will be utilized is on all the important documents that go with an outbreak, so your labs and your partners. It's always going to be 2262. That's Thunder Bay District's identifier number with the ministry. So it's always going to be 2262 dash the year. So this is an example from 2021. So if the outbreak is started in 2022, it'll definitely be 2022, or if it's next year, 2023. So that number is just going to change yearly. And then the last digits of the outbreak number, which you don't see anything on here, as there's not one assigned yet, is going to be the unique number. So it could say 0033, it could be 0001, and that's going to change with each outbreak. So it's always 2262 dash the year dash your outbreak number. And you always want to put the full number, outbreak number down, never just the last digits. So this meeting will mark who is in attendance or absence. Having this list ensures everyone gets the minutes after the meeting. So even if you're not there and you're invited, it should be included on there to ensure that you do get the minutes after the meeting. There's always an opportunity on the agenda for partners to add any discussions to the meeting that they want. So under agenda approval, you see additions. This is your opportunity to add anything on. Case discussion number 3 is to review any of the active cases or any of the initial cases that alerted staff to the outbreak. Number 4 is typically a standing item on all outbreak meetings, and it's to discuss staffing levels. So ensuring that there's enough staff and coverage and coordinating with occupational health and safety. Number 5 is our line list, and this should be covered at each meeting, and line list should be provided prior to the meeting with enough time for review. But we're going to come back to line list a little later on in this module. Other measures that you're going to see on the agenda could change depending on the type. There could or could not be cohorting. There's typically always going to be some sort of IPAC on the meeting as well, and that could just be broken down different ways. ABC, it could just say IPAC. This may be where an inspector might pop in and give their findings, or environmental services. If there's any type of surveillance or testing ongoing, that would be included there. So with influenza or COVID, essential caregivers, this was a common topic with COVID. That's why you see it on this agenda. And then typically you're always going to see number 10, the outbreak status. So what day you're on, the last exposure date to the facility, or the last positive, or the last case associated with the outbreak, and the expected end date. And that's just to remind everyone going into the next meeting where you're standing within the outbreak. Other business is where you have those additions brought up, or anything else that might pop up during the meeting. And again, those frequencies. So how often are you going to meet, and the date at the next meeting. So we keep talking about the OMT, but exactly who is the OMT, that outbreak management team? Well, outbreak management teams from the facility should include representatives from all program areas. So these facility representatives should be able to delegate tasks or have a supervisory or management role with the employees. So some examples likely include a floor manager or floor nurse, a IC manager, so infection control manager, a director of care, or an infection control specialist or champion if there is one for the facility. Frontline staff, such as a charge nurse for the floor or unit, a housekeeping supervisor or manager. It could be environmental services, maintenance personnel, and human resources representative. The outbreak management team not from the facility would include Thunder Bay District Health Unit staff. So staff may include your assigned public health nurse or additional public health nurses for support, the infectious disease manager, public health inspector, or administrative support from the health unit for keeping those agenda minutes. Other stakeholders that could be included would be Public Health Ontario, so PHO, or other governing bodies associated with your facilities. So RHRA, Solicitor General Representative, union representatives, perhaps the LIN. No matter who is on your outbreak management team, everyone on the team does have the same goal, and that's to stop the outbreak as quickly as possible. And they're only going to achieve this by working openly and honestly together.
One of the steps that comes with declaring an outbreak is providing communications to additional stakeholders. The affected long-term care facility or retirement home is responsible for notifying residents, family members, staff, and volunteers about the outbreak and any pertinent details. Having a standard script for communication will assist all staff in providing the same clear, concise message. The Outbreak Management Team, or OMT, will decide if community announcement or communication is required. Typically, Public Health or the Health Unit will do a media release on behalf of the facility.
Facility signage is also an important means of communication and should not be overlooked. Outbreak signage at the entrances of the facility is required to notify all individuals entering. This includes contractors, visitors, etc., and indicates if the outbreak is facility-wide or what units or areas are in outbreak. The units that are in outbreak must also have signage. Signage should be loud and bright to grab attention. Additional precaution signage, such as on resident rooms, indicating PPE requirements is also required. We will go into this further later in the presentation.
We did say we'd come back to line lists, so let's take a look at them now. A line list is a table that summarizes information about cases associated with an outbreak. There should be a master line list of those who meet the set case definition. If the case definition has not been yet established, it would include anyone experiencing symptoms and be adjusted after case definition is met. You don't need to have a positive lab result to be added to the line list. You just need to meet the criteria. Keep staff and residents separate when communicating with your Thunder Bay District Health Unit staff. They need to be reported separately. In order to do that, you will likely keep a master resident list and a master staff line list. These lists must be reported daily to the public health nurse at the Thunder Bay District Health Unit. Typically, a time to have them submitted is established at the OMT to allow the public health nurse to review the list daily, likely before the next outbreak meeting. For example, you may decide by 9 a.m. daily, and Monday, Wednesday, Fridays, your outbreak meeting is at 10 a.m. It is the best practice for facilities to keep the same list as a Thunder Bay District Health Unit. This ensures no individuals are forgotten when transferring information between the lists. If you choose to utilize a different line list, you must ensure the information is transferred appropriately. Line list review is usually a standing item on the outbreak meeting agendas to ensure information is accurate and most up to date. What do we do about suspected cases? Those who have symptoms but don't meet case definition. They may have some of the symptoms, but ruling out medication or waiting on one more episode of a symptom to meet the definition. Some facilities may opt to keep a suspected line list. If they meet the case definition, they are then added to the master list. Other facilities may use a pencil at the bottom of the master list for these individuals and then add them in pen to the ordered list once they meet case definition. Don't include them on the master list within the order if they're only suspected. So let's look at some of these lists. This is a resident line list for a respiratory outbreak. You'll see important information is captured at the top, the outbreak number and the facility. Ensure to put full names as some clients may have the same initials or same last names. If there is shared rooms, ensure the bed number is added. Some will add a numbered list so they can refer to clients by their number and initials in emails to limit personal information being disclosed through correspondence. For example, at a meeting or in an email, they may state line list client number 4, initials AA, has been tested and confirmed COVID positive. If that was intercepted, only those with the line list would be able to identify this personal information. We can't stress enough that when specimens are collected, ensure to input the date it was collected. Commonly forgotten piece of information, but could control the starting or ending of a specific control measures.
This outbreak line list is a gastro or enteric example. So a lot of the same information is looking for identifying information. You can see this one has that number, last name, first name, etc. When looking at this line list, this is for staff. You want to ensure that the date, the last shift and time they worked is on there. So it could be the date and PM shift or the date 3 to 7 PM shift. As that's important because sometimes this can determine the date to declare the outbreak over or the date the employee can return to work. So more information in there, the better, especially for human resources and occupational health and safety in those determinations. It is very highly recommended that line lists are carefully reviewed before the outbreak meetings. Any concerns can be brought forward to the meeting though, so it is good to ideally have one person in charge of the line list at your facility during the outbreak, and this ensures the consistent and accurate reporting. So if daily someone else is taking over the line list, there may be a certain rhythm or style that is used, and then you have to differentiate it every day. If you have like maybe a charge nurse to that floor or unit or a supervisor, if they're just in charge of that line list and that information is brought to them from other employees, that is ideal, and that person would attend the meetings as well. So there are respiratory and gastrointestinal line lists available on our Thunder Bay District Health Unit website. There's 2 for each, resident and staff line list for respiratory and resident staff line list for enteric outbreaks. So you can visit our Thunder Bay District Health Unit website, so tbdhu.com, and in the search bar just put line lists and they will come up easily for you. It was also hyperlinked on the previous slide discussing line lists if you're able to access that. If you're still unsure or having difficulties, you can always reach out to us here at the Hub or to your assigned public health nurse to your facility to access these line lists for utilization.
Specimen collection. TBDHU will typically provide specimen kits, but for some facilities they may have their own. This is to be discussed when you notify the health unit about a suspected outbreak or at the initial outbreak meeting. If you're a facility who keeps kits on site, ensure they are stored properly and that they are not expired. Generally speaking, in an outbreak, specimens should be taken early in the course of clinical illness to increase the likelihood of detecting a causative agent. Specimens should be taken from the most symptomatic and/or the most recently symptomatic, as these specimens have the highest viral load, resulting in a higher detection rate. Enteric sample may be difficult to obtain due to the nature of the collection, so make resources available to aid in the collection of specimens. Detecting a true causative agent can change the outbreak control measures and length of an outbreak. Specimens must be collected appropriately so the lab can test it appropriately. Ensure the lid of the collection container is on and the specimen is packaged correctly and well labeled. Labels must be complete, not just initials. It must include full names and the outbreak number. Including the outbreak number on each specimen lets the lab know to prioritize the outbreak specimens and to collate the results back to you and us so no results go missing. As the final step in the outbreak process, an outbreak debrief is recommended. An outbreak debrief may not always occur, but is highly recommended. The decision to have an outbreak debrief would be determined before the outbreak is declared over. A debrief meeting is a great opportunity to reflect on the outbreak, learned experiences, what was done well, and what could have been done to make improvements for future outbreaks. They could be the catalyst for changes in policies and protocols and future preventative actions. Outbreak debriefs are required for lengthy outbreaks that have a large secondary transmission rate, and minutes should be taken by a facility representative for future reference. In our outbreak process review, we skipped over number 5, and will now elaborate on preventing further spread in more detail in the next portion of our presentation.
The next portion of our presentation will provide details on generalized IPAC measures and how to prevent further spread of infectious agents within a facility. Prevent further spread, routine practices. To prevent further spread of the infectious agent, it is important to put in place outbreak control measures. These include both routine and additional precautions. We're going to start with routine practices. These emphasize the standard level of care to be used by all care providers with all clients during all forms of care to prevent and control exposure and transmission of infectious agents within the facility. Routine practices are based on the premise that all clients are potentially infectious, even when asymptomatic, and that the same safe standards of practice should be used routinely with all clients to prevent exposure to blood, bodily fluids, secretions, excretions, mucous membranes, non-attacked skin or soiled items, and to prevent the spread of microorganisms. Routine practices include hand hygiene, the routine use of personal protective equipment, PPE, but also extend to other elements such as point of care risk assessment, controls of the environment, and administrative controls. The consistent and appropriate use of routine practices by all healthcare providers with all patient encounters will lessen microbial transmission in the healthcare setting and reduce the need for additional precautions. Prevent further spread. Additional precautions. Routine precautions are the standard to be used at all times, while additional precautions are used on top of these routine practices. Additional precautions are for clients known or suspected to be infected or colonized with certain microorganisms. These additional precautions are put in place to interrupt the known or suspected mode of transmission. Typically, additional precautions occur when a client is experiencing symptoms or the client has had a known exposure to an agent. Box 8 gives some examples of additional precautions which are an important part of outbreak control measures. Signage, accommodation, so private rooms or cohorting, additional PPE, dedicated equipment, additional cleaning, limited transport, and communication. Over the next few slides, we're going to break down routine and additional precautions into more details. Additional precautions. Some of the additional precautions, such as specialized accommodation, signage, and PPE, can also be categorized based on the infectious disease mode of transmission and the terminology that we may be more used to hearing. This terminology includes contact precautions, droplet precautions, and airborne precautions. We have listed the PPE requirements beside each of these. A client is not limited to one of these precautions, as they can be mixed. As well with COVID, for example, the minimal is droplet and contact precautions. These additional precautions become the minimal requirements, and additional precautions based on a point-of-care risk assessment could be initiated. So you could increase to contact airborne if a aerosolized generating medical procedure is being utilized by the client in the case of COVID. In some instances, specialized engineering controls may also be required. For example, an airborne isolation room for a patient with tuberculosis, or enhanced cleaning protocols for the client's environment. For example, C. difficile or VRE.
Hand hygiene. The routine practice of hand hygiene must be performed by all healthcare staff and visitors, whether they perform direct care or not, and should be encouraged and promoted with residents as well. Effective hand hygiene kills or removes transient bacteria on the skin. But how do we do that? There are two methods of killing or removing microorganisms on the hands. Number one is hand sanitizing with a 70 to 90% alcohol-based hand rub, or ABHR. This method is actually the preferred method when your hands are not visibly soiled for cleaning your hands. The reason being is it's more easily accessible and takes less time than traditional hand washing. The use of alcohol-based hand rub has been shown to be more effective than washing with soap and water when your hands are not visibly soiled. The second method is hand washing with soap and running water, which must be performed when your hands are visibly soiled. The reasons for this is the effectiveness of alcohol is inhibited by the presence of organic material. Therefore, the mechanical action of washing, rinsing, and drying is a critical contributor to the removal of transient bacteria that might be present on your hands. We often get the question, what if running water is not available and my hands are soiled? The answer is to use a moistened wipe to remove the visible soil and then follow it up with alcohol-based hand rub. A moistened towelette includes those wet wipes you can get at a restaurant when you get ribs or wings. They could be diaper wipes or hand wipes that are also sold in most places now. These can be kept in a company or personal vehicle, purse, work bag, or outing bag. And they are also great for outdoor outings or putting gas into your car. Hand hygiene and transmission go hand in hand. Pun intended. The hands of healthcare providers are the most common vehicle for the transmission of microorganisms from client to client, client to equipment or environment, and from the environment back to the client. Care providers assist multiple clients throughout their day and can be the link between them. Providers use shared equipment and environments, such as shared rooms, and can transfer microbes from the client to these item surfaces. The provider could then transfer the microbes from the equipment and the environment back to the client. During the delivery of care, the provider's hands are continuously touching surfaces and substances, including inanimate objects, client's intact or non-intact skin, mucous membranes, food, waste, bodily fluids, and the provider's own body. Without proper hand hygiene, the risk of transmission is extremely high.
Moments of hand hygiene. So we've talked about transmission, how to perform hand hygiene, and what we need to do it. But when do we use it? This can be referred to as the moment of hand hygiene. So recall transmission occurs through contaminated hands. These moments are to break the chain of transmission caused through our hands. Our hands are the vehicles that can be used to transfer infectious agents between clients and environments, clients and ourselves, and then environments and ourselves. Adding a moment of hand hygiene, either through washing or alcohol-based hand rub, removes that opportunity to transfer an infectious agent. In healthcare, we talk about the 4 moments of hand hygiene and how it's directly related to the client and their environment. So let's look at these 4 moments of hand hygiene. Number 1, before touching a client or the client's environment. So this means the client's environment means their surroundings, their items within their room or their area where you're providing the care. Performing hand hygiene prior to protects the client and their environment from microorganisms carried on your hands, either from the hospital care or facility environment, or from other clients or their environments, or microorganisms that are naturally found on you. So a moment of hand hygiene. Number 2, before an aseptic procedure. So this would also be hand hygiene prior to putting gloves on, is included in here. This protects the client against microorganisms, including their own organisms, from entering their body. So the number 3 is after body fluid exposure risk. So this would be a moment of hand hygiene, likely after removing gloves. And this protects not only yourself, but also the environment from any harmful organisms that would have got on your hand after that bodily fluid exposure. And then number 4 is after touching a client or touching the client's environment. So you'd perform hand hygiene as well, so you're not taking it to the next client or to other surfaces within the facility, or exposing yourself to that client's microorganisms. So these 4 moments of hand hygiene with regulated health professionals is drilled into them. So it's drilled in through their studies and through practice for them to know these moments. But these moments can also be applied when you're not providing direct care. It can also be applied into your facility with all levels of staff, so environmental, PSWs, dietary, anyone working in your facility. So we added some additional before moments and some additional after moments. So this could also look like perform hand hygiene before preparing, serving, or handling food. before taking your break. So perform hand hygiene before you handle your own food you're putting in your mouth, or before you take a smoking or vaping break, because again, you're bringing your hand to your mouth. Always perform hand hygiene before putting your hands on or into boxes of clean PPE so you're not contaminating the outside or other people's PPE. And before using a shared device to decrease that load of microbes with on that shared device. Additional after moments for hand hygiene would be after you've done preparing or handling food, after having your break, so your smoking or food break, because you've now been touching your mouth, your face, your food, so you want to perform that moment of hand hygiene. Something drilled into us since we were kids is after using the washroom, but this would also include assisting a client with the washroom. After taking off your PPE because your hands become contaminated during this. After using a shared device, again, a shared device can have large levels of microorganisms on them, some not familiar to you or that can cause disease. And then after touching dirty garbage or dirty linen would be another moment for hand hygiene. Another time for hand hygiene is anytime you feel your hands have become dirty or contaminated. Hand hygiene and outbreaks. So, what changes with hand hygiene once an outbreak occurs? The practice doesn't change, nor the moments. However, the frequency of hand hygiene will change as there's going to be more clients on additional precautions, and that directly increases the moments of hand hygiene. There will also be an increase of hand hygiene by clients and visitors, as this is encouraged during an outbreak to reduce any transmission. Any facility in outbreak should consider the following: ensuring your facility has an adequate supply of alcohol-based hand rub and all other hand hygiene supplies for use during an outbreak. So additional soap, paper towel, anything that'll be required to perform those moments of hand hygiene. Making sure the products are placed in the appropriate locations throughout the facility for optimal use. So examples would be outside client rooms, within break rooms, within dining areas, and ensuring areas that staff use still have alcohol-based hand rub available as well. So if it's a office area, that those are also stocked for them too. This may be increasing locations during an outbreak as well. So at the entrance to the facility, maybe increasing the amounts of mounted locations or having those freestanding to have additional alcohol-based hand rub. Assigning someone to the responsibility of refilling the soaps and alcohol-based hand rub on each shift, and it's important to not have empty containers or run out during the outbreak or any other time. Since there'll be an increased use of them and increased locations, someone should be monitoring those at all times. Sometimes your facility is unable to utilize alcohol-based hand rub from wall units or having the alcohol-based hand rub left out. So if that's a concern, you can definitely have containers kept on person, ensuring staff have easy access to replace the individual on person ones when empty. We have seen individuals have those on lanyards that are tucked under their scrubs or that they're kept in their pocket, or they'll have mounted containers that are locked are options too. Another thing during outbreaks is increasing auditing of hand hygiene practices along with the donning and doffing practices. So direct observation would be of the practice of performing hand hygiene, and indirect would be looking at the usage of products. So monitoring the amount being used. So everyone's supposed to be performing hand hygiene before entering this room. However, everyone entering this room, this many pumps, if it's not adding up, then that indirect method showing that there are failed moments of hand hygiene. There is a tends to be a trend with outbreaks. If there's a low compliance with hand hygiene, it's correlated with a longer outbreaks. And the reason for this typically is that there's larger secondary transmission between clients and staff, which prolongs the outbreak. So really important to audit and ensure that compliance so you can reduce the length of the outbreak and the outcomes of that outbreak. As we go through this module, we're also going to stop and talk about some lessons learned about each topic. So these are situations that we've learned from previous outbreaks throughout our years with infection control. So the first one here is lessons learned with regards to hand hygiene. So facilities not having sufficient alcohol-based hand rub or hand sinks available, or they have the lack of alcohol-based hand rub wall units, or bottles are missing from where they should be, or not having a designated location for them. We do understand sometimes it can be a very difficult situation when it can't be left out in the facility. However, utilizing portable sinks may be required to ensure that clients are hand washing or staff are able to keep up with hand hygiene. And as we spoke earlier, you can also have staff keep individual size alcohol-based hand rub on person as a way to go around that. Another issue that we have seen before is not having the proper product. So less than 70% or a non-alcohol based hand rub. So this is still not acceptable for healthcare facilities. Healthcare facilities should have at least a 70% alcohol content within their alcohol based hand rub. Alcohol-based hand rub not in the proper areas or being inaccessible. So hidden in areas where it's not visible to visitors or staff, just being poor location, perhaps a lack of signage where to find it, or placed in too busy of area. So I was at one facility before and it was on the wall, but you couldn't see it because there was about 10 posters all around it and it just kind of blended in with the wall and the posters. So ensuring that it is very visible to the visitors or staff or those who are not common within that facility, that it's present, it's there, you know where to find it, so it is used that way. Hand hygiene can also include the misuse of gloves, so especially missing the steps of hand hygienes when putting on or taking off the gloves. So typically those who are using gloves, they may replace glove use with performing hand hygiene. So I kind of call it the Superman effect. When you have gloves on, you feel like you can touch anything, where really you're missing those moments of hand hygiene. So you're touching everything, you don't feel the dirt, you feel invincible, you feel you're protected, but really you're contributing to the spread. So only wearing gloves when necessary, so you're not missing those very important moments of hand hygiene. And then complacency would be the last one. So it's very important to have all frontline staff watch or re-educate on hand hygiene prior to the outbreak season or when the outbreak is declared. People are naturally complacent about everything in life. It's just natural for us human beings. We're kind of like water. We like to take the easy route. We all know we have to wash our hands and we all know the certain moments we should wash our hands, but we also know the speed limit when we're driving. But however, how many people probably drove over the speed limit today or every day? Um, so even though we know increasing our speed puts us and others at risk, we still do it every day. But that's why we have speed limit signs, and then we also have officers who enforce these speed limits. The same thing kind of can be applied to hand hygiene. That's why we like to talk, relearn, practice, have that signage, and then we kind of have our own enforcement around it. You know, having that auditing, that re-education, that educating in the moment. That's all simple things can really prevent illness, prevent the spread, and make a better outcome from the outbreak. So reducing that illness, reducing that spread could in fact be saving lives.
Our second routine practice is the use of PPE or personal protective equipment. PPE serves as an additional barrier to the potential exposure of infectious agents and should be utilized appropriately, depending on the care being provided at any time, not just an outbreak. This is what makes it a part of routine practices. All care facilities must provide adequate supply, easily accessible, and appropriate personal protective equipment to prevent staff, volunteers, and students, as well as visitors from contact with blood or bodily fluids, secretions, excretions, non-intact skin. PPE includes the use of a mask or an N95 respirator, eye protection, gloves, and gowns. On this slide, we're going to discuss a bit about audits for PPE and hand hygiene. PPE practices are ongoing. The use of PPE should not be new for your staff, but when you're in outbreak, the moments of use can go up exponentially, and this can often be confusing for staff who have never experienced an outbreak or cared for individuals under additional precaution. This is where training would need to occur. In addition to ensuring your staff are appropriately trained, audits for routine practices should also be performed. If they are routinely done, then the number of audits should be increased. Infection control audits ensure ongoing review of a setting's processes and infection prevention and control practices, for example, policies and procedures. Audits verify that all IPAC best practices are being followed by all staff. In outbreaks, it can be extremely helpful to increase the amount of audits being performed in an outbreak area for practices such as donning and doffing PPE, as well as hand hygiene. Auditing these practices and doing in-the-moment education can increase compliance and help keep staff and residents safe. Lessons learned with PPE. Lessons we have learned in the past outbreaks and things we have seen which contribute to longer outbreaks and increased transmission can include staff not understanding the use of masks as universal precautions in relation to the COVID-19 pandemic versus its use as PPE, including the steps on when to remove and change PPE to better protect themselves and their clients. The extended use of eye protection can lead to the same kind of issues as seen with universal masking in the COVID-19 pandemic. Not processing or reprocessing, cleaning and disinfecting at the proper moment, improper storage of eye protection, so worn as PPE and then potentially thrown into a purse or a drawer with other items that are handled without proper hand hygiene, etc. And knowing if extended use is in place within your facility and increasing awareness and education on reprocessing of eye protection would be key. Another lesson learned is the misuse of gloves that was seen throughout the COVID-19 outbreaks in many facilities. Staff wearing for activities that do not require the use of gloves. For example, screening, walking around the facility, or attending training sessions. We saw many instances where staff would be wearing gloves throughout the facility, drinking their coffee, touching their hair and their cell phone, etc., missing many steps for hand hygiene and contributing to the spread of infectious agents and potentially extending the outbreak for much longer. We also in these instances saw staff washing their gloves as opposed to changing them and or performing hand hygiene. Having staff do audits by walking around and observing PPE use and doing in-the-moment education would be a great improvement for these processes. Gowns were also observed to be worn down the hallways to the doffing area that were potentially misplaced or worn from room to room as they potentially lacked the training and knowledge that gowns should be single-use and not worn from patient to patient. Again, this is an indication for education and potentially assessing the placement of a PPE station. The mentality or thought process for many individuals who had been observed misusing PPE was that they were protecting themselves, but unaware that they could be contributing to the spread throughout the facility and actually harming others and increasing their own personal risk. Although IPAC has been at the forefront during this pandemic, it is important to continue to refresh and educate staff on proper IPAC practices to best protect themselves and their clients. Your facility may have new staff who have never experienced an outbreak or attended our IPAC 101 course. Ensuring that they are up to date on IPAC requirements and changes is essential in the safety of your clients and your staff. So we've talked about PPE and auditing PPE, but now we'll talk a bit about the principles of the PPE cart setup. PPE carts or stations hold all the necessary supplies required to implement additional precautions, for example, droplet contact precautions. The PPE stations need to be set up at the first sign of symptoms, the first symptom. This should not wait for the outbreak to be declared. Additional precautions are based on the client's symptoms, not the outbreak declaration. Additional precautions are to stop the spread at first sign. PPE carts and stations should be located outside of the room of a symptomatic resident. For some units, placing a PPE cart outside the room may not be practical. Determining a location that is suitable, for example, the nursing station, and post a sign on the resident's door communicating that PPE is to be worn and where the PPE is located. A doffing area and a garbage container location must be just inside the room or just outside to ensure dirty PPE isn't being worn outside of the environment, potentially contributing to spread. Signage is required with the garbage can to ensure proper doffing of PPE. We're going to go into this a bit more in the next few slides. The setup or arrangement of the cart itself can be important. Ensuring it holds all the necessary supplies and those supplies are accessible yet kept clean. PPE should be stored in order to protect it from dust and droplets. We usually recommend drawer units or covered cart options versus an open shelf. The over-the-door caddy is also an option if space is limited, as it keeps supplies clean and contained. This should be placed on the outside of the door. If it were to be placed on the inside, it would most likely be within 2 meters of a symptomatic client. The caddies should include a clean box of masks, gloves in various sizes, gowns, and a way to reprocess eyewear, or somewhere to dispose of eyewear and have new sets available. There should also be alcohol-based hand rub on top so no moments of hand hygiene are missed. If this isn't possible due to safety reasons, it can be carried on person as well. There should also be access to environmental wipes to wipe down any shared equipment, such as a blood pressure cuff or vitals machine. Ensure there is also staff that are dedicated to restocking the PPE carts.
Signage is also important with PPE stations during outbreak. It is ideal to prepare for outbreaks by having your additional precaution and outbreak signage ready to put up and an adequate supply. This saves time on trying to find the file, print the posters, laminate them when you're already in outbreak. Having them printed and available and stored with the PPE stations ahead of time allows for quickly putting up the signage and giving direction to your staff and visitors. Using plastic sheet protectors are a great way to store the signage. It also allows you to put it up quickly and easily just with double-sided tape or masking tape. It's plastic so you can wipe it and sanitize it if required. It also allows you to switch out signage quickly and easily. So if there's if precautions change or new signage is updated, as we know with the pandemic, signage definitely has evolved throughout it. It just makes it easier as well. We know there's a lot of signage developed for long-term care homes and acute care, and it's not always been compatible with our other facilities. So at the IPAC Hub, we have developed some signage, and it is available on our website for you. You can see one of the signs right here. So with the universal facial protection, donning and doffing look differently. So everyone already had mask and eye protection on. However, Public Health Ontario's donning instructions shows you when to put those on. So for those who weren't super familiar with that terminology and maybe new to the medical field, we just wanted to lay it out step by step, have it really easy for individuals to follow. So that's why we created some of our own signage. If there's signage that you find your facility is lacking, definitely contact us at the IPAC Hub and we'll work with you to create that signage, something that's easy and versatile, and then we can share with all our facilities as well. Because if you find you're needing it, likely another facility or organization is also looking for that. So signs should always be bright and to the point. Bright colors stop people, catch their attention. It helps differentiate from other daily posters and signage as well. It also needs to be direct so it's easy to follow. Simple terms, pictures, anything that's just easy that you can kind of in a list form. Ensuring your facility has adequate signage and supply of signage and having it in place quickly ensures less confusion and can also help contain the spread quickly. Signage for PPE station should be put with the station where the user can easily see it. So if it's instructions how to put PPE on, you're going to put it where the PPE is located. You're not going to put it across the hall behind them because they're going to have to turn around to see what they're supposed to put on each time. So the donning should be put with the PPE station, and then the doffing, so taking off that PPE, ideally you would want to put it where you are going to be doffing and where the garbage can is. So you're not going to put donning and doffing right beside each other. You're going to put donning with the PPE station and then maybe on the other side of the door or inside the door where the garbage can is going to be. That's where you're going to put the doffing signage because that one indicates that's where you're supposed to be taking it off. And second, gives you instructions right where you need to see it. So talking about garbage brings us to the next point here, number 8, and that's PPE and garbage placement. So in an ideal world, the garbage can should be accessible within the threshold of the room. Where you're providing that care. So ideally you want anything that's clean or like the clean PPE on the outside of the additional precautions area, and then inside the room would be the dirty area or like the dirty PPE area. So you wouldn't want to be exiting that room with the dirty PPE if possible. So you can do that as long as you're more than 2 meters away from the bed or the direct care area. However, what we found with a lot of facilities isn't feasible or always available. So if it can't be right inside the threshold, right outside the threshold. However, we want that separation between the PPE station and the doffing garbage. You don't want the PPE station and the garbage right next to each other because cross-contamination can occur. So if possible, designate one side for putting on and one side for taking off. As you can see in the bottom picture, the most ideal situation is the top left. Other times, you can have like an alcove with a bunch of different people on precautions. So we would rather you see individuals travel a little bit further distance with clean PPE on than travel further with dirty PPE. So these are 4 rooms here, let's say all on precautions. You would go into one room, doff at that threshold, so I kind of did a dotted line, go back to the PPE station, put on new PPE, go to the next room, doff it at the threshold, go to the PPE station, put on new PPE, go into the third room, doff it within its threshold, exit, go back to the PPE station to don, enter the fourth room doff within its threshold. So again, you're not going to room with the same PPE on. You're still disposing of that PPE in between each room, but you may have shared garbages as long as they're accessible from that threshold area, because we're not concerned so much there, because you are going to be doing hand hygiene after, and you're not walking across the alcove or across the hall to go to that doffing station. It's still within arm's reach from that doorway. So your layout of your facility will definitely determine placement. We have done site visits with our facilities just to determine where they might put it during an outbreak, or this has been a common situation when we have done site visits during outbreaks, or inspectors who have been on site, or nurses who have indicated just wrong placements and suggested better placements for them, or doing mock outbreak situations. Where would you put these stations? So if you need any assistance with that, you definitely can reach out to the hub and we can be assistance with you. We are familiar with most of the facilities. If we haven't been to your facility before, we can definitely come and do a quick walkthrough and kind of identify where the ideal situations would be. So this segues nicely into our lessons learned. So all about PPE cart placement, signage, and garbage, things that we have learned through previous outbreaks. So we have seen in past outbreaks the poor implementation of signage and the PPE carts and the impact it's had. So a negative impact, meaning a longer length of the outbreak, and the negative outcomes of that outbreak. So one thing would be the PPE carts or stations, their placement too far away from where it's used for be, or not stocked with the right supplies. So this can confuse staff what they should be following, and also increase the risks to their safety going in without all required PPE. So example would be PPE at the entrance to a hallway to where individual rooms are off of, so let's say 10 rooms. Well, ideally you would want a station every so many rooms rather than just to the hallway, as this confused staff thinking they had to wear it in the hallway, the PPE within the hallway, and that once they left that hallway, they would take off the PPE, not in between each room. Also a lack of alcohol-based hand rub at these stations or on person. So this again increases the moments of hand hygiene, the misses there, and it can increase the risk of transmission. So if you don't have access to alcohol-based hand rub or a hand sink for when you're donning and doffing PPE, you're now putting that staff member at risk and the clients that they're serving at risk as well. So that was a big missing one, or inadequate amount. So wall placements or on the carts themselves. The signage not getting up. So you can't identify where these additional precautions are required. So signage, rather than placed on the doors for those clients, were kind of placed on walls in between. So again, the confusion, are they wearing it in the hallway? Where are they supposed to wear it? Are they supposed to wear it with the client, in the hallway, both? We learned from staff within facilities that was confusing for them, because again, newer staff, large turnover during the pandemic, newer circumstances with COVID. Signage not being up or identifying the right identifier. So doffing signage at the PPE cart and then the donning instructions at the garbage can. So again, the incorrect instructions at the wrong place. So those who are not familiar with it, putting it up, or just overlooked mistake, it can create confusion, because if you're standing at the doffing cart trying to remember the order to doff and there's only donning instructions, you're going to be guessing. And then again, you're increasing the risk to yourself as a staff member in that incorrect process. A big thing we do see is with the garbage cans. So garbage cans being placed right next to or against a clean PPE cart. So with the garbage cans, a lot of time what can happen is PPE can overflow, especially if it's not being bundled up tightly and being placed in that PPE garbage, or just the heavy use of it. So cross-contamination can occur between the dirty PPE and then the clean cart and that clean PPE. So there needs to be separation between the two. So ideally, that's why we say on either side of the doorway. If that's not possible, put the garbage right next to the door and the clean PPE further away. Ensuring at least, I would say, 2 feet distance between the two to ensure that there's no cross-contamination. If the garbage is placed too far away from that designated room or threshold, that leads to individuals walking through clean environments with dirty PPE, and it can result in the spread. So those were some of the main lessons learned in regards to carts, signage, and garbage.
Our next topic is on environmental or housekeeping IPAC measures. So this would include your cleaning staff for your facility. So regardless of the outbreak, and like all other staff, facilities should cohort and dedicate housekeepers to the outbreak unit only, and if possible, increase the number of housekeepers on this unit to keep up with their rigorous cleaning schedules. Within the outbreak, housekeepers should move from the well to the ill. If there is a break in precautions, this reduces the risk of the well individuals becoming ill. This is obviously going to look a little different for every facility. Some small facilities will only have one area and no units. So it's very important to move from the well to the ill residence then. So you'd be cleaning the well residents or clients' rooms first before ending with the ill residents' rooms. So you also have to ensure that they're taking proper care to protect themselves and others. Environmental cleaning staff should have the ability and affect other clients just as much as the individual who provides care for these clients. So we see this occur often with daycares and vomit spills. So there's improper hand hygiene or PPE use, and then the spread of illness occurring after. So that brings us to PPE for our housekeeping or environmental staff. So ensure proper PPE practices are upheld by all housekeeping staff or environmental services staff. If this is not a process they use daily, they may need to be refreshed or re-educated on how to do this, ensuring that they're just not given a sheet of paper, this is how you do it. Have them watch videos or have them practice. Ensure they are comfortable doing the process as well. Because if they're not, there could be a lapse, they become ill, and then you're down more staff and your outbreak is prolonged. So this includes the use of gloves, gowns, and masks when cleaning clients' rooms and adhering to strict hand hygiene practices. Increasing the number of staff is due to the requirements to clean more often. So most facilities have already had this in place since the COVID pandemic started. However, many of the facilities may be lessening this now with the current status. During an outbreak, there are many more garbages from PPE that need to be cleaned and taken out. There are more spills to clean up. So individuals becoming ill maybe unexpectedly in the hallways or on the floors in their rooms. So that's something to consider too. Planning staff and having retention staff for the outbreak is important planning. So ensuring that there is a plan in place to address that. The other area is cleaning and disinfecting products. So the proper selection of products to effectively kill the infectious agent that has caused this outbreak. So you want to ensure the cleaner and disinfectant is the right product for what you're battling, and you're also using the right process for those products.
So this was something that all facilities should be aware of after COVID. Ensure that you're always reading the fine print and make that kind of ensures that you have the right product. Is it a cleaner? Is it a disinfectant? Does it do both? What is it effective against? Environmental cleaning managers should be aware. If you don't have this title or resource within your facility, perhaps you're one of our smaller facilities and you are the environmental supervisor. You can always utilize your public health inspector that's assigned for your facility. They can help you with that, or you can also reach out to us and we'll help you figure some of that out as well. Laundry IPAC measures. PPE for staff handling laundry. Just like environmental staff, ensure they are re-educated on how and when to use PPE and have adequate access to PPE. Location of laundry carts on floor and handling of soiled linens. So limit the amount of sorting being done if possible. Minimize moments of contact as much as possible. And keeping up with strict hand hygiene practices. So limit the sorting and contact as you don't want to aerosolize. You just want to kind of keep everything nicely folded and compacted together and bringing it to the dirty linen area. You don't want to be fluffing and sorting and spreading droplets and infectious agents all over in that area. Your hands always have that potential of contamination, so ensuring that you're doing the moments of hand hygiene either after taking off gloves or after coming in contact with bodily fluids. So again, this is looks different between long-term care facilities and smaller facilities, but the key points are to protect yourself when handling laundry from those on those additional precautions. Having the knowledge to know what PPE and when to wear that PPE is really important. So we have our last lessons learned slide here regarding environmental services and laundry. So the first one would be products. So products use has created some difficulties during COVID, initially due to the supply. There was a really hard time to find certain disinfectants when the pandemic first started. That doesn't seem to be an issue anymore. The next thing that we encountered was the ongoing issue of unfamiliarity of products. So those who haven't been exposed to choosing a disinfectant before, exposed to environmental services before, just ensuring that they were using the correct product. So we did have some companies and suppliers marketing the product incorrectly or donating the products improperly. So hand sanitizing wipes were being used as disinfecting wipes for surfaces. So ensuring that, okay, it's an alcohol wipe, but is the manufacturer directions used for just hands or is it for disinfecting surfaces? So again, reading that fine print. We do see this continually at all times, using a disinfectant as both the cleaner and disinfectant. If it is a disinfectant and truly just a disinfectant, you need to clean first. Cleaning always comes before disinfecting. So ensuring that you are using the product for what it's intended for. There are some products that are both a cleaner and disinfectant, but it does have to state that on there and you have to use it according to the manufacturer's directions. So procedure error, this is not adhering to the contact time required for the disinfectant to properly work. So this could be either not enough product being applied to the surface so it evaporates too quickly before that contact time is achieved, or it could also be wrong concentrations being mixed. So if you have a ready-to-use product and you're diluting that, then it's not the right concentration anymore. Or if you're using a concentrate straight, it's going to be too strong or just the wrong calculation. So ensuring that you are familiar with the product, if it's ready to use, if it's a concentrate, the right dilution factor. Another thing is not having enough trained staff or external contracts available. So you're not having enough staff to maintain this knowledge within your program, or you don't have the ability to have a contract with an external cleaning company. So again, if you have questions about products, you can always reach out to the supplier or your public health inspector or us, and we'll definitely assist you the best of our ability. But ensure that you are following all directions at times. The last one would be PPE. So glove use is a big thing, always, 12 months a year. So gloves being worn between dirty and clean laundry. So using gloves to handle dirty laundry and then those same gloves to handle that clean laundry. So that's a point of transmission or a lack of hand hygiene moment there. So that extended use of gloves can be very detrimental. And the gloves being used for tasks when not required. We see this quite often too. So individuals are wearing gloves to sweep a floor or push a cart. This isn't required, and it again makes that false security, that Superman effect of touching everything without feeling the dirt or feeling the need to perform hand hygiene. So again, you're missing these moments of hand hygiene. Gloves should only be used when required. They shouldn't be just used in addition, or you feel like it, or it makes you feel safer, or your hands are cold. None of those reasons should be used to utilize gloves. So again, only using them when required.
Some points to consider as we discuss IPAC in regards to respiratory and enteric outbreaks include the infection prevention and control and PPE requirements for COVID-19, influenza, and other respiratory enteric viruses are similar. Facilities should review proper use of PPE and hand hygiene based on infection prevention and control resources, ensure sufficient supply of PPE, hand hygiene, and cleaning and disinfectant products, consider the amount of PPE that would be required based on the number of staff members and potential usage with or without an outbreak within your facility, and review and reinforce cleaning and disinfection procedures, including twice daily cleaning of frequently touched surfaces during outbreaks.